I'll make a brief video of barbiturates out of respect for them. They still have some therapeutic uses today. They're the granddaddy of sedative hypnotics. We've had them for over 100 years, and for a long time they were all we had for managing insomnia and for purposes of sedation. But they were definitely habit forming. They have a low therapeutic index, and so they are used today, but not for management of sleep disorders. Still some uses for sedation and also for seizure management. We don't think of these drugs, barbiturates, as being GABA receptor as having a mechanism of action at the GABA receptors, but they do potentiate the action of GABA. That means they help them, they sort of work alongside and aid or support the action of GABA. They inhibit nerve impulse conduction on along pathways to the cerebral cortex. In lower doses, they are sedatives. Higher doses, they do put you to sleep, but they can also cause respiratory depression. We just don't use them anymore as hypnotics. Barbiturates were categorized as ultra short acting, short, intermediate, and long acting. And the ultra short acting are possibly used for short surgical procedures as anesthetics. They're given parenterally, they're given IV. So thiopental, for example, or methohexital are ultra short acting that are useful for anesthesia. You've already encountered a long acting barbiturate in the past in our lesson about anti-epileptic drugs, phenobarbital. And so this is useful in treating seizures or epilepsy. There are boatloads of adverse effects of the barbiturates, as is so often the case. The first class of drugs we find with a particular action, it works, but it has more adverse effects. Cardiovascular, including hypotension, respiratory, including respiratory depression, which I've already mentioned, can have negative effects on the bone marrow, blood forming, so that we can end up with with agranulocytosis and thrombocytopenia. We can end up with Stevens-Johnson syndrome, reaction in the skin. So big risks. And these drugs really tended to reduce the amount of REM sleep the users were experiencing, leading to possible agitation. Toxicity of barbiturates, overdose, whether accidental or intentional, would typically cause death because of the respiratory arrest risk as well as the CNS depression with coma. And so it's a big deal if somebody accidentally overdoses on barbiturates. Back in the day when these drugs were used more for sleep, we would hear of a lot of accidental or intentional overdose deaths due to barbiturates. There are strategies to deal with overdose of barbiturates. These are central nervous system depressants, and you'll learn a little bit about withdrawal from these drugs in chapter 17. But for management of overdose, you may need to put the patient on a ventilator because respiratory depression is an outcome of overdose. Also, there are ways to decrease the reabsorption of the drug in the kidneys. They're excreted through the kidneys by alkalinizing the urine, giving IV sodium bicarbonate, and by diuresing to help them eliminate it faster and prevent reabsorption. So overdose can be managed, of course, but now that the barbiturates aren't prescribed so much, we don't worry quite so much about that. They're not used. They're not out in the community as much as they once were. There are a lot of risks of drug interaction. Barbiturates, as I mentioned in another videotape, induce liver enzymes that break down lots and lots of drugs, and so they shorten the duration of action of a lot of other drugs. I didn't even list them here because there's so many. If you give these drugs with other central nervous system depressants like alcohol or benzos or opioids, additive effects, increased risk of central nervous system depression. MAOIs, inhibit the metabolism of barbiturates and so on. So we are used to seeing some of these drug effects with other medications. So barbiturates, limited use these days, not for hypnotics, but because you can still see them in other for other uses. You need to have a basic familiarity with them.